This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Laura, Research Fellow. Today we're looking at a fascinating new study from the journal World Neurosurgery, published in 2026.
This paper is titled Cerebrospinal Fluid Shunting in Hydrocephalus Secondary to Leptomeningeal Metastases, a systematic review and meta-analysis of functional outcomes, symptom improvement, and complications. Ilara, this is a topic that hits home for many of us in the clinical setting because leptomeningeal metastases, or LMM, is such a challenging diagnosis to manage.
Absolutely, Dr. Aris. As the paper points out, LMM frequently leads to hydrocephalus. The pathophysiology here is primarily due to impaired cerebrospinal fluid flow, which results in elevated intracranial pressure. For the residents listening, we know this manifests as those debilitating neurological symptoms that significantly impact a patient's remaining quality of life.
Right. And as neurosurgeons, our role is often centered on palliation in these cases. We use CSF shunting, including ventriculoperitoneal and lumboperitoneal shunts, as a primary palliative strategy. But as the authors of this study note, the current evidence has remained quite fragmented. We've lacked a robust quantitative synthesis of what these patients can actually expect.
Exactly. That's why this meta-analysis is so timely. The authors aimed to evaluate the clinical outcomes and the safety profile of these procedures, specifically for hydrocephalus secondary to LMM. They really dove into 4 key pillars: functional outcomes, symptom reversibility, survival, and, of course, complications.
Let's talk about those functional outcomes first. In the context of terminal malignancy, functional improvement is a high bar. What did the meta-analysis find regarding the clinical state of these patients post-shunt?
The study focused heavily on functional outcomes, often measured by scales like the Karnofsky Performance Status. The data suggests that while we are looking at a palliative population, shunting can lead to a measurable stabilization or improvement in functional status. It addresses that elevated intracranial pressure mentioned in the abstract, which is often the primary driver of their functional decline.
Right, and that ties directly into symptom reversibility. For a medical student rotating on the service, they might ask, if we place this shunt, what symptoms are we actually fixing?
The paper is quite specific there. By diverting the CSF, we're targeting the symptoms of hydrocephalus directly. This includes the relief of headaches, nausea, and vomiting associated with high ICP. But more importantly for the family and the patient, it can address gait disturbances and cognitive changes that occur when the CSF flow is impaired by the leptomeningeal disease.
It's about restoring a level of dignity and comfort. But we have to balance that with the survival data. Shunting is an invasive procedure. Did the meta-analysis provide clarity on survival post-procedure?
It did. The study looked at median survival post-shunt as a critical metric. While shunting doesn't treat the underlying leptomeningeal metastases itself, it manages the lethal complication of hydrocephalus. The synthesis of the evidence helps us provide more accurate prognostic information to families about how much time the shunt might actually buy in the context of their systemic disease.
Now, let's get into the safety profile mentioned in the study. In my experience, shunting in the setting of malignancy carries a different risk profile than, say, idiopathic normal pressure hydrocephalus. What did the systematic review highlight regarding complications?
This is a crucial point for practicing neurosurgeons. The meta-analysis looked at the safety profile specifically for this LMM cohort. They categorized complications into a few bins: infection, shunt malfunction, and the theoretical but serious risk of peritoneal seeding of the malignancy via the shunt itself.
Malfunction is always a concern, especially when the CSF might have a high protein content or high tumor cell burden, which we often see in leptomeningeal disease.
Precisely. The fragmented evidence of the past made it hard to quantify that risk, but this study's systematic approach gives us a clearer picture of the rate of shunt failure in this specific population. It allows us to weigh the symptom reversibility against the likelihood of needing a revision surgery in a patient with a limited life expectancy.
It's a classic neurosurgical trade-off. We are looking at a palliative strategy where the goal is to mitigate debilitating neurological symptoms while minimizing the time the patient spends in the hospital.
And that's why the quantitative synthesis this paper provides is so important. It moves us away from anecdotal evidence and towards a data-driven approach for LMM-induced hydrocephalus. It helps us decide whether a ventriculoperitoneal or lumboperitoneal shunt is the right call for a specific patient.
Well, this has been a great dive into a very necessary study. It's clear that while CSF shunting remains palliative, its role in improving functional outcomes and reversing symptoms is backed by this new synthesis of evidence.
Agreed. It's a must-read for anyone managing these complex patients.
Thanks for joining us on the Neurosurgery Hub podcast. We'll see you in the next episode.
Goodbye, everyone.